Mini-bypass, mini-quadriplegia, simplified ultra-rapid filtration. Yes, it's a little bit quick, but is it the future? The Smurfs. Maybe you don't know them. Yes, it's New York on the background, but they come from Belgium. Our mini-bypass system had integrated arterial filter from Terumo, FX05 up to 2 liters per minute, FX15 2 to 5 liters, oxygenator was set up higher, vacuum drainage, therefore we could use smaller tubing size, and we set our system closer to the surgeon. The prime was ringer lactated base. On every 100 ml of ringer, we gave 10 ml of albumin 20%. Also, heparin was calculated by the amount of prime, mannitol by the kilograms. RBCs were used when hematocrit was lower than 20, cyanotic 28, and if we used blood, we would do pre-hemofiltration and add bicarbonate if needed. This is a graphic about the patients that didn't receive any blood. You can see that the group under 10 kilos received 32% of them blood products. This is because we don't have any dedicated systems for them. In this slide, you can see the blood use. For one, more red blood cells were used because we didn't have very small sets yet. Also, you see a little bit more increase in FFP use. But in all patients, there was no need of thrombocytes or other blood products. New measurement of looking at bleeding of different pediatric patients. It's milliliter per kilogram. As you can see in this slide, number 51, what was 5th timed operation, and we have no cell saver for children in this hospital. So there was an increase in this patient. And the other 4 peaks you see were the patients that were not closed by the primary surgeon. Here you can see the bleeding milliliters per kilogram, also increasing by decreasing the weight. And again, this is because we didn't have any sets. We had to use blood. So there might be a correlation of giving blood and more bleeding. We used St. Thomas. This was by gravity, cold around 7 degrees. We didn't use a hot shot then. Extra quadriplegia was given 20 to 30 minutes. When we started with mini quadriplegia, this is cold blood, only potassium, magnesium added. Also, before removing aortic clamp, we did 3 minutes of hot shot in most cases. Extra quadriplegia was given between 20 and 30 minutes. In another hospital where I worked, we did 4-to-1 quadriplegia. Cold also 12 degrees, most cases also hot shot, and extra quadriplegia every 20 to 30 minutes. The difference in defibrillation in percentage. The St. Thomas solution was 4 times higher as the mini quadriplegia, but also the 4-to-1 blood quadriplegia was also almost 4 times higher. There was no difference in lidocaine use in the 3 groups. Hemofiltration. We use hemofiltration always in difficult patients. If we had to put red blood cells into the prime, we use pre-hemofiltration. During bypass, if needed, and sometimes at the end of bypass. Smurf was done after bypass. Here you can see our hemofiltration use in the patients. In the beginning of St. Thomas, we had to use, of course, quite a bit of hemofiltration. But when we started using mini cardioplegia, we could decrease these. In 2017, you see it increase again because of the difficulties of operations. This is the result of SMERF on the hematocrit. The hematocrit increased by around 100% and was lying between 45 and 55. SMERF, we have to give less volume to the anesthesiologist, about 50% less. It takes much less time than the MUF, between 3 and 5 minutes, and this is after bypass. Safer than the MUF. It's because the system is not connected to the patient anymore. Here you can see Dr. Argun. He's our cardiologist, and you can see he's pointing out how difficult of patients we are doing in open heart. Here you can see the proof. The increase of perfusion times and aortic times are going much up. In the beginning, we did still a few VSDs, ASD, but in 2017, we didn't have any more of these patients. You can see the increase in operations, in perfusions. 2017, of course, is not finished. Cardiology, interventional for all VSDs, ASDs are done by interventional cardiology. Standby increased a little bit. Total amount of patients are now already same as in 2016. You can see that the amount of reoperations are at the moment about 50%. But even with the increase of reoperations, the bleeding per milligram per kilogram decreased, and this is not because of patient size. So the conclusion, less bleeding with more reoperations. What is interesting? But our surgeon now closes all the chests. Maybe that gives also less bleeding. Here you can see me behind the S3 pump. This is the newest we have now in open heart. We try to minimize the gadgets on the pump. These are the perfusionists I'm training at the moment for pediatric perfusion. As you can see, we always do these cases with 2 perfusionists now. These are Laurel and Hardy. You can see they're totally different size. Should we, not like pediatric perfusion, also take different sets for adults? You can see the amount of hours average that patients are on the respirator. In 2013, there were quite a bit of very difficult cases, so we could see longer time. Also in 2017, but I will show you in next slide what is a better way of looking at the patients. Here's, I think, a good evaluation of how we are managing the patient. It's ventilation less than 5 hours. You can see that overall in most years it's the same. This way we can look at the patients who are ventilated more than 5 hours. In 2013 it was so low because there were only 4 patients that we did that time. Here's the respirator time of the different patient size. So we have to maybe look in the future in different patient size on average of ventilation. Here you can see the ventilation time less than 5 hours. Also in this graphic, the group of less than 10 kilos has a lesser percentage. Here you can see a normal ICU bed after cardiac surgery in a modern hospital. What you didn't see in the last picture is the most important, I think, the mother, the best nurse in the world. This is now a routine in most hospitals, is the sign out. It's quite important to do this. Georgia, we did it a little bit different. Surgeon, anesthesiologist, intensivist, and cardiologist, and me as perfusionist did the sign out with food and drinks. This is the way it should be. On second postoperative day, the child dancing in the hallway. I would like to thank all the people from Open Heart Hospital in Tbilisi, Georgia, for their cooperation, hospitality, and great work. Last, I would like to thank my parents. Because of them, I'm on this world. Thank you very much.